All right, there we go. Excellent. Okay, thank you for the introduction. It's a tough act to follow with Yuri going before me, but Yuri has already set a lot of the groundwork, which makes my job a little bit easier, actually. So these are my disclosures. As Yuri talked about, you know, that the origins of these more advanced thyroid cancers, essentially, the poorly differentiated and the anaplastics are, you know, late stages of more well-differentiated thyroid cancers. So your papillary, follicular, and Hürthle cells, and these have distinct molecular profiles, as you just heard. And what is really what we've really come to learn and has helped us more recently treat these more advanced thyroid cancers is that these cancers do retain those driver mutations. So a papillary thyroid cancer that has a BRAF V600E mutation that then transforms by acquiring, you know, late event mutations that still retains that BRAF V600E mutation, and so that is a targetable mutation. This just shows essentially what I just said. Is that as we move towards the less differentiated thyroid cancers, we have accumulation of these late event mutations. But again, the driver is retained. And here, what I just want to point out is, you know, this again is kind of the same concept of this spectrum moving to the right from well-differentiated to more poorly differentiated and anaplastic. And what happens in this process is that we get a higher tumor mutation burden, we get higher number of mutations really, and tumor mutation burden. We start seeing more TERT promoter, P53, EFAX mutations, PI3 kinase mutations along the PI3 kinase pathway, SWI/SNF, mismatch repair, and histone methyltransferases. So I'm going to talk a little bit about each of these concepts in the more advanced thyroid cancers. So as Yuri pointed out, MAP kinase pathway, very, very important in thyroid cancer. And then there's also the PI3 kinase pathway. And we have a number of drugs that can target along both of these pathways, targeting particular mutations, targeting the receptor kinases. And then we also have drugs that target along target mTOR, which are important. So I do want to start by saying that tumor mutation burden in anaplastic thyroid cancer in general is low. We sometimes will see some ATCs that have a very high tumor mutation burden, but they're rare. So the higher mutation burden tumors are like melanoma, squamous cell carcinomas of the lung, you know, bladder, whereas you see thyroid's all the way on the left side of this spectrum of tumor mutation burden. And that also applies to anaplastic thyroid cancer, although it's higher than more well-differentiated thyroid cancers. And so what does that mean for prognosis? Well, what we know is that in poorly differentiated thyroid cancers, higher mutation burden confers a poorer prognosis. So here in red are the patients who are above the median of mutation burden, and then the patients that are below the median and at the median. And you see that overall survival really decreases in the patients with higher mutation burden. And mutation burden is also greater in older patients. It's associated with tumor size, and it's associated with distant metastases. So I already talked about the driver mutations, or Yuri talked extensively about the driver mutations along the MAP kinase, PI3 kinase pathways and how those are retained in more advanced cancers. We talked a little bit about acquisition of late event mutations. And so what I also want to discuss SWI/SNF, mismatch repair, cell cycle gene alterations, and tumor immune evasion genes. So this is a very nice study that was a combination of Foundation 1 panels and the MSK impact. This was published in 2018 and really was the biggest series of ATC patients And they also had, and so we had also the MSK impact information. So using these two panels, we were really kind of able to understand a little bit more about ATC molecular pathology. And essentially what I want to point out here, I know it's difficult to look at these things very quickly, but what's important is here on the left is that 41% of these tumors have BRAF mutations, which is great for us because we can actually target those. About 20% are NRAS, 14% have PI3 kinase mutations, 11% have P10 mutations, and 9% NF1. So looking at the differences between poorly differentiated and ATC, you see that about 33% BRAF mutated and poorly differentiated in the MSK series, whereas 45% in ATC. So these, are pretty comparable. Same thing with NRAS. We still see all the RAS mutations coming along from PDTC to ATC. We also see mutations along the PI3 kinase pathway, much higher in ATC than in poorly differentiated. So 39% in ATC, 11% in poorly differentiated thyroid cancers. And PI3 kinase mutations, I wanted to talk a little bit about what the significance of that is. So we looked at our patients who had cfDNA that had ATC, and we do see that patients who have PI3 kinase mutations actually have a poorer prognosis. So here are the PI3 kinase wild type, and these are the PI3 kinase mutated, and you see a very significant difference in overall survival. And it doesn't seem to matter what we treat them with, right? Whether they're treated with surgery, cytotoxic chemo, radiation, or BRAF inhibitors, they still do worse. So those mutations along the PI3 kinase pathway may need to be targeted in ATC. We have recently submitted a paper on somatic mutations in ATC patients. And we've presented this previously, so I'm able to present it here. But my colleague, who's a surgeon, Jennifer Wong, put this together, and it just shows the MD Anderson data. So very, very similar to what's already published. Nothing surprising here, about 41% BRAF mutations and about 22% NRAS mutations. And what this study, though, contributes is that we know what the clinical data are, right? And so this is what we are seeing in terms of overall survival in patients with ATC, depending on what mutation they have. Patients with BRAF V600E mutations here in green are the ones that do the best. The ones that do the worst are RAS mutated. This is, very striking difference. And then patients that have neither, somewhere in between. But RAS mutations were associated with more than 2.5-fold higher risk of death. And so when we identify these patients, we really try to treat them as aggressively as possible. BRAF inhibitors are fantastic. I'm going to talk a little bit about this in my next talk, but I wanted to point out that although BRAF inhibitors really have made a massive impact in their survival of these patients, look at what happens after the first year. These are patients who are BRAF mutated, who are on BRAF inhibitors. You see they start falling off. And so, so something happens at 1 year. That something is that they develop resistance. And so we need to really kind of better understand how to manage these patients. This is the phase 2 of the Dabrafenib study that was recently updated, and the median overall survival was 14.5 months. So that's pretty much what we're seeing also. What happens after the first year is that patients really start to die. What else is targetable? Well, we've got fusions, and Nikki Forov spoke a little bit about that. RET-PTC, PAX8, ALK mutations. We see these in both poorly differentiated and anaplastic thyroid cancer, but they're very, very difficult to find. And so, when you come across one, you get really excited, but the problem is that we don't then know what to treat these patients with. This just shows that we do have inhibitors for these different mutations. Okay, I want to move on to TERT promoter mutations in thyroid cancer, and you see only 9% in papillary thyroid cancer. That increases to 40% in poorly diff, and then 73% in anaplastic thyroid cancer. And so this is, you know, a striking difference between the well-differentiated thyroid cancers and the more advanced thyroid cancers. And what happens is that basically this really does impact their survival, right? So these are patients with TERT promoter mutations, and these are the wild type patients. So a striking difference between survival in these patients. And so at the moment, we don't have a way to target these, but obviously these are, these do seem to be prognostic. P53 mutations, you know, in poorly differentiated thyroid cancer, in this Landa study, it was 8%, much higher, 73% in ATC. And I think, you know, that is one of another one where we can't really target it, but we know that that's prognostic. Okay, and then I want to talk lastly here about effects mutations, because these are rarely seen in papillary thyroid cancer, so only 1% in TCGA, and then 11% in both anaplastic and poorly differentiated thyroid cancers. So it's really interesting because they usually coexist with RAS mutations, which in and of itself have a poor prognosis. And this diagram here, I know, is a little bit complicated, but the bottom line here is that these mutations, along with RAS mutations, activate mTOR. And so if we know that these are activating mTOR, then you know, that may give us a clue as to how to treat these patients, since we do have mTOR inhibitors. So that's really the bottom line of what happens here with these effects RAS mutations. A little bit about mismatch repair. Essentially, you know, the damage to DNA is supposed to be repaired, and when that doesn't happen, and when we have a mutation in a mismatch repair, and we have real issues with repairing the DNA. When we look at mismatch repair in, when we look at mismatch repair defects in anaplastic thyroid cancer, we see it's about 6%. And so these are possibly targetable. They're much more common than in poorly differentiated thyroid cancer. So in this series, it was 2% in poorly diff versus 12% in anaplastic thyroid cancer. And what we know about mismatch repair is largely from colorectal cancer. And so these are the studies from colorectal, where you see that patients that are treated with pembrolizumab who have high MSI-high colorectal cancers, they do much better than patients who are treated with chemotherapy. So this, you know, this pembrolizumab is now approved for all types of solid tumors with mismatch repair defects. And so we don't have much in the way of data from thyroid. This was basically a single patient in this pembrolizumab study for MSI-high tumors. I can't even really find it on this graph. I suspect it's somewhere lost in here, but we don't have much data is the bottom line, but it is approved for this indication, and so that can be used in patients who have MSI-high. Unfortunately, I don't really see this much in anaplastic thyroid cancer or in poorly differentiated thyroid cancer. I don't know if Dr. Nikiforov can comment about that later, but it's not something that I'm seeing very often. And so I'm almost never able to use pembrolizumab under this indication. SWI/SNF is becoming a really hot topic now. These complexes consist of a number of different mutations. So we have ARID1 mutations, SMARC mutations, and ATRX, which are the most common ones that I am seeing in poorly differentiated and anaplastic thyroid cancer. And essentially, these are complexes interact with some activators and repressors and mobilize nucleosomes. They remodel chromatin and they repair DNA. And so when you have defects in this, you have issues with repairing the DNA. In poorly differentiated thyroid cancer, 6%, but in anaplastic thyroid cancer, much higher, 36%. And so these are really becoming very important to identify, and possibly, they're possibly targetable because we believe that these patients would respond to immune checkpoint blockade. So why is that? So here's an example of ARID1A. When it's not mutated, right? It interacts with MSH2 and regulates the positioning, which then allows it to repair the DNA damage. When you have a mutation here, that can't happen, and so then you essentially have this functional defect in mismatch repair. And we talked about mismatch repair previously, and using immunotherapy. And so we believe that immunotherapy may be the way to treat these patients that have these SWI/SNF mutations. There are some proposed targeted therapies for patients that have SWI/SNF, but I don't know that this has ever been really attempted in thyroid cancer. But we have drugs that target HDAC, SARC inhibitors, PARP inhibitors, and CDK inhibitors. But I don't think that anybody has really done any type of clinical trial in ATC or poorly differentiated thyroid cancer as of yet with any of these. So a little bit about the immune landscape of ATC. So this is actually quite important, and there's a kind of a striking difference between the well-differentiated thyroid cancers and the anaplastic thyroid cancers. PD-L1 is highly expressed in ATC tumors, whereas in poorly differentiated and anaplastic, we don't see it as highly expressed. And if you look at PD-L1 staining, you see that there is that it does predict prognosis in ATC. So this is a really interesting finding, because obviously PD-L1 is targetable with checkpoint inhibitors. As I said, the immune microenvironment really becomes much hotter in anaplastic thyroid cancer, and so this is something that we can try and harness. And there's a real difference between the response rates of patients who have differentiated thyroid cancer here on the left, where we had a 9% partial response with pembrolizumab, and a 19% response in ATC with spartalizumab. So these are, the landscape, the immune landscape is very different in these two tumors. Sorry about that. Let me do that again. Okay, so this is a study with spartalizumab where we have high PD-L1 expressing patients up here and low expressing PD-L1 patients in ATC. And you see that this is the responses in the PD-L1 expressing group are not only higher, but up here they're higher. However, the patients also lived a lot longer. So we do look at PD-L1 in ATC patients and in our poorly differentiated thyroid cancers. Just a quick, animal model. I'm not going to go much into this, but essentially, BRAF inhibitors with immunotherapy, lenvatinib with immunotherapy in an ATC orthotopic model. Essentially, what we're seeing here is that the animals that were treated with both targeted therapy and immunotherapy had better responses and longer survival. So basically, we ask, do all roads lead to immunotherapy in ATC? We know that they express a lot of PD-L1. We see TREGs and CD8s. We see mismatch repair defects. We see SWI/SNF mutations. And so, you know, what we do at MD Anderson is essentially try and put all patients on immunotherapy when we can, but we usually combine it with targeted therapy because immunotherapy does take a very long time to work. But I do think that immunotherapy is probably going to extend the lives of these patients. And so we're already doing this at MD Anderson. This combination, depending on what the patient's mutation status is. So a patient that, for example, has a BRAF mutation would go on a BRAF MEK inhibitor plus immunotherapy. And so we're studying this. I'm going to hopefully publish this trial this year. We also have some clinical trials that are open at MD Anderson and other sites around the US with combining BRAF MEK inhibitors with immunotherapy. And, you know, if patients have other targetable mutations, it's possible that you could combine some targeted therapy with immunotherapy in these patients. The patient maybe has EFACs, you can imagine doing, you know, everolimus in these patients, possibly with immunotherapy. We already have lenvatinib pembrolizumab studies for these patients. So I'm going to go more into detail about management of ATC in my second talk, but this is essentially, I think it kind of all boils down to, you know, how we translate this information into clinical practice. And so this is kind of my summary of what I think we should be doing in ATC. So with that, I'll end. And I want to just highlight the ATC team, which we call FAST at MD Anderson. This group has actually grown quite a bit now. And so we're a fairly large group trying to see all the ATC patients that come to us. We're seeing probably about 2 to 3 per week, which is overwhelming. But I think we're learning a lot from this, and hopefully we can see some of your patients in the future. Thank you very much.